for joining.
Usha, are you doing the needful? Sending to Rita?
It's there on the flyer. The link is on the flyer.
Oh, okay, then I'll tell her that.
No, link is received in the email. The link on the flyer is registration flyer. So they have to register and then they will get the email to join.
Participants been let in. Hello? Dr. Sibal, we just need to check if the participants have been let in.
Yeah, there are quite a few hundred people in, so they are.
Okay.
So I guess they'll keep coming in. Right, we'll. Good morning to our colleagues in North America. Good afternoon to our colleagues in Europe. Good evening to our friends in India. Really delighted to be able to be a part of this program today, where we are interacting with nurses and hearing about what they have to say, hearing their voice. And GAPIO is privileged to be able to host this event. GAPIO, for those who are not familiar with, our organization was established in 2011, and the aim is to bring together 1.4 million doctors of Indian origin on one platform. And we now have members from 53 countries. Today's program, we have Professor Arun Garg, who's up at 6:30 a.m. in the morning in Vancouver. In British Columbia in Canada, we have Dr. Seema Arora from the US. We have Dr. Vinita. It's getting late in the evening for her in Manila. And of course, we have colleagues from different parts of India and from the United Kingdom. You'd be happy to know that we really want to forge a very strong relationship and a bond with the nursing community, nurses of Indian origin. And among the numerous activities that we have undertaken in the last 1 year, we have also put together several position papers. And one of those position papers, and Tangam and Usha and Clara have been instrumental in putting it together, has been about nurses and the role they play in healthcare and what is it that we can do to enhance their role. It talks about upskilling, it talks about nurse subspecialization, it talks about career progression, and it really addresses the core issue. The issue that is very dear to many of us is about empowerment of nurses. So nurses enjoy the status, the position that they enjoy in the West. And I think it's a journey. We have made significant progress. And I think there is a lot more to be done. And I think occasions such as the one that we have today helps reinforce our commitment to the nursing community. We've seen now it's day 494 of the COVID pandemic, and we've seen how admirably nurses across the globe have worked. They work 24/7. They've put everything else aside and focused on patient care. They have been working tirelessly away from their families and giving 100%. And that's why they say if they are angels on earth, then they are our nurses. So we really like to express our gratitude on behalf of the medical community to all that you do, and how beautifully you do it every day and do it with a smile, how you've taken the pain, the misery away, and how you've helped so many families get a smile back on their face. So thank you very much. We will start the program, and it's a privilege for me to be able to introduce our moderator, Professor Arun Garg. Arun Bhai is a professor at the Fraser Health System in Vancouver. And in addition to his clinical work, he's played an instrumental role in forging a very strong relationship between Canada and India. He founded CINI. He organizes numerous conferences and hosted the GAPIO conference in British Columbia a couple of years ago. He is very passionate about looking at holistic health and has done a lot of work in integrative medicine, Yoga is a passion, and of course, his knowledge of Indian spirituality is phenomenal. So, with those words, I'm going to hand over to Professor Arun.
Thank you. Thank you, Dr. Sybil. Namaskar, good morning, good evening, good afternoon to a global audience from beautiful British Columbia, Canada. I am speaking from unceded, familial, and traditional territories of First Nations of this province. This is a tradition to invocate and acknowledge the history of this country and the First Nations who founded Canada. I want to thank GAPIO, Dr. Anupam Sibal, and Dr. Anil Tandon for this invitation and participation in this session. GAPIO, a global organization whose I am an executive council member, is a unique stewardship organization which promotes and builds network of collaborative projects. During COVID, GAPIO has been a leader under Dr. Sibal's leadership to bring thousands of physicians and other health practitioners for learning about this invisible enemy. So thank you, Anupam Bhai. Doing this with deep commitment and engaged and build sustainable networks. GAPIO recognizes critical role of health practitioners and the team. GAPIO has commissioned several projects to build strong support and engagement between all health providers and members of GAPIO. It's really a privilege to chair this special session on Nursing Hour to celebrate and honor International Nurse Week. The International Day of Nurses celebrate life and contribution of Florence Nightingale, the icon of Victorian culture, lady who set the standards and the professionalism in nursing, lady with the lamp. The day was established by International Council of Nurses in 1965 to celebrate work of nursing profession, nurses, word, nurses who nurse the word back to health. We acknowledge the profession and a special recognition during COVID as frontline workers, care providers at great personal commitment and sacrifice. We reach out and celebrate nurses all around the globe. International Council of Nurses aptly declares International Council of Nurses aptly declared 2021 as the voices to lead a vision of future healthcare. The year will focus on changes to and innovation in healthcare and how it will shape the future of healthcare. We at GAPIO join you in this inspirational goal and salute you. We in GAPIO join you in this inspirational goal and salute you for your contribution to health and healthcare and all areas of healthcare, be it quality of healthcare delivery, preventing of hospital-acquired infections, patient safety, and direct care to nurse patients back to health. With that gratitude in my heart, with that gratitude in my mind, I welcome and thank all speakers, chairpersons, and all of you who have joined us for this session. Thank you. Housekeeping for the attendees, please send your questions in the chat box because there will be time for QA. Now, friends, ladies and gentlemen, it is indeed a great personal pleasure and privilege for me to introduce our keynote speaker, Dr. Captain Usha Banerjee. Dr. Banerjee is a group director of nursing at Apollo Hospital Group. Prior to this, Captain Usha was the group head at Manipal Hospitals and Max Health Center. Captain Usha has been awarded with President's Medal, Army's Headquarters Medal, and many other coveted and prestigious awards for academic excellence. Captain Usha is also recipient of many other national and international awards like Healthcare Management Asia Award, FICCI Award, National Women's Excellence Award, and Rotary Club Delhi Central Award for involvement in social causes for women and children. Captain Usha has recently been nominated as member of the Indian Nursing Council by Ministry of Health, Government of India, as its core member in FICCI. At this time, I request Dr. Usha Banerjee to deliver keynote speaker. Dr. Usha Banerjee, over to you.
Namaste and greetings from India. It's an epic moment in the history of the world as healthcare workers, doctors, nurses, paramedics, and other workers battle it out on a brutal war at the front line, supported by back-end people. I think it's time for us to pause and pay tribute to all those COVID warriors who've laid their lives in the call of duty. We pay homage to all those patients, their families, and the citizens of our countries who have lost their lives. We also salute every single worker for relentlessly working to save lives today at the battlefront. While doctors have got great recognition in this COVID crisis, which they so richly deserve for leading the medical care in every country, I think the largest contingent, the nurses, work silently, relentlessly, tirelessly, unseen and unheard. And I think it's time for a national glorification of this fraternity and this profession. The world also gears up to celebrate the International Nurses Day, which is on the 12th of May, to celebrate and commemorate the birth anniversary of Florence Nightingale, the founder of modern nursing. Her policies of the late 19th century and the early 20th century in infection control and medical care have paved way to practice today. She was a formidable voice to reckon with. She was a voice that was heard, and she led. I take this opportunity to thank Dr. Anupam Sibal for giving the nurses of many countries to be here on this platform, and for many of them to join in to listen to what we have to say. Thank you to Dr. Tandon for giving all the guidance to make this possible today. Thanks to Professor Dr. Arun Garg for chairing this session. Today, amidst this cacophony of clinical trials, evidence-based medical practice, artificial intelligence, big data, cloud computing, which has enabled us to practice medicine and nursing with mathematical accuracy and robotic precision, one thing is very, very clear, that the role of the nurse will always prevail. She will truly be the advocate for the patient care. It's time for us to disrupt traditional power structures and for leveling traditional hierarchy. Healthcare, I represent my country, has been traditional, rigid, orthodox, and patriarchal for a very, very long time. It is important for us to position the nurse in the right manner in the organization and in the policy making in the country to ensure that we have the best practice and the best care provided to the citizen of our country. It is time for us to emulate the healthcare system and the nursing practices from the best of the world. And I'm glad I have colleagues here who stand in to state what I say. It is time for us to recognize the contributions of the nurses in this country. It is time for us as nurses to lead with our voices. Hard work isn't enough. We need to find our edge. We need to sink our roots into the earth. We need to communicate. We need to remove barriers. And we need to be titled as the heartbeat of the healthcare system. When the heart stops, it's over. We no more the unsung heroes. We are the heroes. And it is time for the medical fraternity, for the community, for the patient, for media, for all the social groups to recognize that this profession is one of the most important profession that supports the clinicians to enable to give the best care to every citizen or every loved one who stays back in India. And I'm glad these partnerships are going to grow, and this will enable us to learn from the best of the world. And I'm sure this is going to benefit every single nurse in this country. I thank the delegates and the participants. And at the same time, I thank these wonderful participants and the people who are here on the panel, whom I know very closely, who are passionate for the cause of nursing and who've done so much for this country and beyond. I wish this conference reaches out to every single member and we grow as a fraternity, both in India and abroad. Thank you so much.
Thank you. Thank you, Dr. Usha Banerjee, for those inspirational words. I think those words will not only be heard during this conference, but they will make it real of the message for International Year of Nursing for 2021. So thank you for sharing those. At this time, I would like to introduce the chairperson for our next session, Dr. Seema Arora, who will then introduce speakers. Dr. Seema Arora is a board-certified internal medicine physician practicing in specialized medical aesthetics in Massachusetts, United States of America. Dr. Seema was chair, board of trustee of American Association of Physicians of Indian Origin for 2019-20, past president of Indian Medical Association of New England, United States, and past president of Lady Harding Medical College Alumni Association of North America. Dr. Seema is co-convener of GAPIO's Women's Forum. At this time, I would like Dr. Arora to chair the session. Over to you, Dr. Arora.
Thank you, Dr. Garg, for that kind introduction. So I have the pleasure to introduce and invite the first speaker today, Lieutenant Susan Adamala, for her presentation. Ex-Lieutenant Susan Adamala is working as clinical nurse consultant for clinical documentation and adjunct faculty, University of Illinois, Chicago, and Rasmussen University, Illinois, Chicago. Ms. Susan is also working as COVID ambassador for the Illinois Department of Public Health. She has served as a board member at Illinois Department of Professional Regulations and was a visiting professor at Chamberlain University, Resurrection University, and North Park University. She is the only nominated Indian nurse in the IDPFR board, entrepreneur, NCLEX training business. Ms. Susan is honored with the Best Clinical Nurse by Indian Nurses at the Association of Illinois and the Best Nurse Leader nominee by Indian Nurses Association of Illinois. Please welcome Ms. Susan. Over to you, Ms. Susan.
Thank you very much for those kind words, Dr. Arora. I have only 8 minutes. I have a lot to say, but I have only 8 minutes, so I'm just jumping into my topic. Can you all see my screen?
Yes, we can.
Okay. So greetings to everybody from the United States of America. At the very outset, let me thank GAPIO for giving me this opportunity to represent the Indian nurses in the United States. It's really a privilege to be among the many eminent speakers for today. And I really, really thank you for giving nurses this platform, which was way overdue because, I think COVID put us in the forefront. So now everybody's paying attention. And for that, I have to say thank you to COVID. And, we are showing our presence in the worldwide healthcare scenario now as nurses. So today what I'm going to talk to you is about the impact nurses have on overall patient outcomes. So WHO defines outcome measures as change of health of an individual, group, or population that is attributed to one intervention or a series of interventions. So the goals of healthcare system, no matter which country or where it is to improve patient care experience, improve the health of the populations, reduce per capita cost of healthcare, and reduce the burnout of clinicians. So what is the role of the nurse in the overall, overall patient outcomes? We want the best outcomes for our patients. And we know that best outcomes come from clinical confidence. A doctor is present at the bedside for maybe 10 minutes, 15 minutes, or 20 minutes, but the nurse is there with the patient throughout 24/7. She's the eyes, ears, hands, mouth, everything for the patient and the doctor. So if we have good clinicians at the bedside, it directly translates into good patient outcomes. So how do we prepare this nurse? In the United States, the nurse is the coordinator for patient care. A patient may have many physicians, many specialties taking care of this patient, but the nurse is the one person who would coordinate the whole care, and she explains everything to the patient. She advocates for the patient. She is there as a representative, as a voice for this patient. So it is a big, responsible, very accountable job. You are dealing with lives. You cannot make mistakes. So it requires preparations accordingly. So the education system for nurses has been very well established. From a vocation that it started, we are now a profession. And this profession gives people the degrees that they need to practice at the bedside. They can come out with an associate degree or a diploma in nursing or a bachelor's degree or a master's degree to practice as entry-level bedside nurses. After they take the, I'm talking about the perspectives or the way things are practiced in the United States, because I'm representing United States right now, although my training was from India, from Armed Forces Medical College. So after the nurses get this entry-level degree, they are expected to go through an exam, which is not that easy. It's a National Council licensure exam, which is the NCLEX exam that they have to take. And once they take this exam, then they are given the title of an RN, which means a registered nurse. So once they get this registered nurse title, that's when they apply for jobs and they go and start their job. So when they go into the job, they are given at least 3 months of orientation. When I came to the United States, I had 14 years of experience in India and in the Middle East as a critical care nurse. But even so, I was given at least more than 3 months of orientation into the ICU, because even though I didn't need it, that was a system, that was the plan for the hospital, the way they take in their nurses. So they make sure that the nurse understands, even though she has experience, understands everything about the healthcare delivery system in the United States, so that she becomes an efficient caregiver at the bedside. There's clear-cut job descriptions that is laid out for each nurse or what level they are performing, so that there is no role ambiguity at all. Then once these nurses work at the bedside for at least 2 years, then they're allowed to go into take up any of their certifications of their specialty. So if they are a critical care nurse, they can go in for a CCRN certification. It is not mandatory that every nurse should be certified, but nurses who want to grow in their profession will definitely be supported with advice, resources, even the money to do the exam and to prepare them for the courses some hospitals are giving them. And then they're also given extra pay for certified nurses. So this really motivates nurses to keep growing in their profession, to become better and better at the bedside. And once you get the certification, you are supposed to renew the certification every 3 years or 2 years, depending on the certification. So for that, they are supposed to keep up their latest and be abreast with the latest knowledge. So they have to keep up with the CEU. So to maintain our RN's license and to maintain the certification, for RN's license, it is 20 CEUs or continuing education units that they have to have, which means like 20 hours of education to renew their RN license. And for certification, it's 100 CEUs every 2 or 3 years, depending on the certification, so that they are well-versed and they know everything that's happening in their field of practice. We also practice evidence-based practice or of medicine. And so the latest trends and whatever procedures and policies are there, that is available to the nurses at the bedside on their computers. So if for example, there's a change in policy related to how to insert a Foley catheter, there, the nurses can go up online, check immediately what is changing, and the nurses are given periodic in-service education for anything that is new or that has changed. So that way they're keeping up with their skills, they're keeping up with the latest in the field of practice. Critical thinking skills cannot be underestimated at all. A nurse with a good critical thinking is the one who will save the patient, who's able to do good assessment on her patient and is able to foresee the complications that are happening and to prevent them. So that is the kind of nurses that we want in our healthcare system, right? And the most important of all is this job security, perks, opportunities for professional growth. This is something that I really think that India needs to work a lot on. If we fix this one problem, I'm sure that there will be no attrition of nurses at all. Nurses will not go looking for the job to another country. Why do nurses leave? Because nurses are not given, they are not, first of all, in our culture, I'm sorry to say this, but people look down upon nurses. People think that nursing, if you're not good with anything else, if you can't become an engineer or a doctor, then you should become a nurse. You become a nurse. That's not true. If we don't have people with intelligence and those who only obey orders, those nurses will not be saving the patients. We need people who are critical thinkers. We need people who know what they're doing. We are not there just to take orders. We should have the knowledge to question the orders from the physician. If the order is against or wrong, or if somebody made a mistake, if we didn't need to do that, there was no need for us to go to for a 4-year degree course to get this bachelor's degree to practice as nurses, right? So this job security will come only if there's pay rise. They are able to live have a good, decent lifestyle. In the United States, people look up to RNs. Last year, it was the 18th time in a row that the Gallup poll showed that nursing is the most trusted profession of all professions in the United States. And this is something for the nurses to be proud of. And this is something that every nurse all over the world should enjoy, that their profession is considered as the most trusted profession. And that's because of the way the society has given place to the nurses. We have good perks, we have opportunities for professional growth. The masters and the certifications that I have behind my name has come free for me because my hospital or organization where I have worked, they have paid for this. So nurses don't have to worry about, oh, who will pay or what will I do? So once these things are taken care of, then automatically the social status of the nurses will go up and more people will start coming into the profession. So patient outcome measures, what are some of the measures? I know this is like a very busy slide and there's not much time for me to explain anything here, but this is just a slide from the hospitalcompare.com where anybody can go and look up and see, you just put in your zip code of your place where you live, and then people can choose which hospital to go. What is the rating for safety in this hospital? What is the rating for readmissions for pneumonia, CHF? What is the patient care experience? How effective the care is? How good the nurses are in communicating, the physicians, how well they communicate to the patients, what is the timeliness of care, how efficiently they are using the EHR, and how transparent this data is. All these are just some of the measures. There are like 59 measures on the hospitalcompare.com, and there are other websites too, like Leapfrog and other things that people can look up. So we have a very informed consumers now. So if we want to give the best care, we have to be the best at what we are doing. So we have to be transparent. We have to make sure that all these measures are met by our organization so that people will want to come and have the best care that we can deliver to them. So there are some departmental strategies and organizational strategies. Because of lack of time, I'm not going to go over every point. If we want, we can discuss this later if somebody needs more clarification. So I would just read through just to, to respect the time. So a patient-centered care is very important. Our patient should be involved in every decision that we make for his or her care. A well-established orientation plan, which we discussed. Shared governance, meaning that the nurses at the bedside should have voices and their input should be considered in making policy and procedure changes. foster self-directed lifelong learning for the nurses, have career ladders where the nurses can get promoted and given opportunities to precept, to mentor, etc. Succession planning for leadership is very important, and recognition of proficiencies. So this is important at the departmental level. In an organization level, we should always involve, and that is what I want to talk to all the all the healthcare leaders who are here in this podium or in this panel, that always involve your chief nursing officer or your chief nurse executive in critical decisions that are related to the delivery of care, because nobody knows that what happens at the bedside better than your nursing staff. So take their input and make use of their knowledge at the bedside to make changes in your policy so that your patients get the best outcome. Equal voice in the boardroom. Conferences with nursing representation, and this is what we are doing right now with GAPIO, that we are given a voice, we are given a day, and thank you so much for this, where we have nurses talking about us so that everybody in the world understands where we are, where we come from, and what is our input in bringing about the best that we can as clinicians at the bedside. And recognizing nurses at organization levels and visibility of leadership at the grassroots. This is something that I would like to emphasize. Sometimes we are so busy with meetings or leadership stuff that we have to do, we forget people at the bedside. So making yourself present, going and taking rounds, whether you are a CFO, a CMO, a CEO, or CNO, whoever, if you go periodically to the bedside, see what people are doing at the grassroots levels, you will totally understand what's happening, and you will be able to make changes which are for the better. And collaborating opportunities at national and international forums, just like what we have now, is something that organizations should foster. So how do we unleash the potential of these nurses? I look at this in just like the Maslow's hierarchy of needs that we do. We have, and this is not new to us, we are familiar with this. So in the beginning, when a nurse is coming into the profession, she is in this level of, trying to make a living she's working to get food, clothing, shelter for her family. So she is in the basic physiological safety and level. And then she becomes a member of the team, and she goes into this, to team member, a camaraderie that develops, and she has this, she goes into the next level, that's a level of love and belonging. And once she does that, then she becomes, a part of that unit or part of that floor, and she starts becoming certified nurse. She starts mentoring other nurses. She becomes a preceptor, and now she has a self-esteem that she is one of the best in her profession. And after this, next comes the self-actualization level, where the nurse is thinking about, oh, I have got so much from my profession. What do I do to give back to my profession? And we find policies and procedures, and we make changes. And as what we are doing now, like Dr. Banerjee and other people in my Madam Gomez, and so many other people who are actually leading their organization or leading in nursing, are actually giving back to the profession, because they know what is wrong, what can be fixed, and that's the way to go. And we want all our nurses to climb the Maslow's hierarchy all the way up to self-actualization. We need to understand that nurses are invaluable assets to society, and investing in them is what is needed, because you will invest on something that is very valuable, right? So if you think your nurses are valuable, you will invest in them instead of ignoring them. You want to provide care for them as caregivers. You provide them work-life balance so that they don't quit nursing and go into something else, because this is so, they are burning out in their profession. Recognize your nurses for exemplary work. That is the way to improve the image of nursing. We ourselves as nurses have to improve our image, as well as a society who is actually the recipient of our professionalism should be improving the image of nursing, accepting us as professionals with intelligence, wisdom, character, skill, knowledge, attitude, everything. Empower our nurses and then become autonomous in our practice. So we know that we can't achieve this alone. Together, everyone achieves more, and we need our whole healthcare team, our ancillary staff, our physicians, our organizational directors, people in leadership, everyone together to collaborate, to support, protect, and to promote. Only then we can bring out the best clinical outcomes for our patients. That is all I have for you now. If you have any questions, you may ask now, or maybe we can save it for the end of the day as per the plan from our organizers.
So thank you very much, Ms. Susan. I think we will keep the questions for the end. That was an excellent speech, and I think very informative about the role of nurses and the great education that they go through here. And also, I second that they're such invaluable assets, and we definitely do need to recognize and empower nurses. And that's how, we are going to, set examples and increase also the patient care, and also make more nurses come into this position, which is really, really needed right now. So thank you very much for an excellent talk. And now I would like to invite my next speaker for today, and that's Dr. Jyoti Clara Michael. Dr. Jyoti Clara Michael is currently working as Director of Nursing, IHH Healthcare, India, Glendale's Global Hospitals Group, and Continental Hospitals. Prior to this, Dr. Jyoti was associated with CMC Hospital, Vellore, India for more than 32 years. Dr. Jyoti has also worked as Chief Clinical Governance Officer at Kaveri Corporate Office and Director of Nursing and Quality, Glendale's Global Hospitals Group, Hyderabad, Chennai, Bangalore, and Mumbai. She also worked as Assistant Dean for Clinical Affairs, Sultan Qaboos University, Muscat, Oman. And she was a member of National Advisory Board of Research, Sultanate of Oman. Dr. Jyoti has been awarded with Most Innovative Healthcare Leadership Award, International Travel Award from Midwest Nursing Research Society, Deanship Training University of Wisconsin, and the Atapai Research Award for the annual Atapai Chapter Research Day held at Oshkosh in 2005. Please welcome Dr. Jyoti Clara Michael, and the stage is all yours.
Thank you very much. That was a very pleasant introduction of yours. And may I wish the GAPIO for giving me this opportunity, specifically Dr. Sibyl and Dr. Tandon and Usha. The time is very short and the topic that is given to me is very vast. And I would like to keep the topic very simple, grounded, so that I wanted to give my experience, what I have helped through learning, that I have taken my institution forward, applying evidence into practice. We started a very humble and a simple beginning 10 years ago in the group where I am belonging to. Over the past 2 decades, I could see in India, the evidence-based nursing practice has been evolving, and it is very gradual. It's just leaping slowly and increasing because of the increasing hospitals going for JCI, NABH, and also educational institutions going for NAC accreditation. There has been always a need to reduce the cost in India, and also to optimize care and quality, safety, and also to achieve a desirable clinical outcome. So this is a very, very difficult part when you mix all three together, and certainly evidences help us a lot. Do not clamp urinary catheter because patients get readmitted with cystitis. Do not use povidone on granulation tissues. The wounds doesn't heal faster. Nurses using predictions for sepsis, cardiac arrest, and preventing patients entering into ICUs and length of stay increasing. All these are happening in day-to-day life that we are seeing, and that is all because of the increasing number of qualified nursing leaders entering into healthcare in India. Knowing is not enough, we must apply. Willing is not enough, we must do. This is the motto with which we have to go forward when it comes to evidence-based nursing practice. When we talk about evidence-based nursing practice, if we fail to address the work, the wonderful work Florence Nightingale has done, she has sent a beautiful message for all our nurses those days itself. The most important practical lesson that can be given to nurses is to teach them what to observe, how to observe, what symptoms indicate improvement, what the reverse, which are the importance, which are of none. Evidence-based practice is applying and translating research finding in our daily patient care practices, and clinical decision. So this is what we have to teach nurses, and we are doing it, but it is not enough. Studies show that nurses are interested. They are very positive about evidence-based nursing practice because they are getting more empowered. They are having a job satisfaction. They are being powerful in front of the clinical team, and they go back home after their duty timing with a great satisfaction that they have done something for the patient. But still, we face significant barriers in implementing it when our initiatives are coming as nursing initiative when we take the lead among the multidisciplinary team. So here comes something that is going for our thought process, that nurses need empowerment. The previous speaker told it very clearly on this. 90% of the nurse research leaders also specified that hospital uses evidence-based nursing practices, and it also says that models helps us. So when we had started 10 years ago in our institution, we started off with a model because models helps nurses to understand in a simplified manner how they have to translate the evidence into bedside practice. Here, my topic is going to be focusing on how evidence-based models can be applied in our day-to-day life in our practice, and how a simple nurse who is standing in front of a patient in a ward can very easily translate it, and also she can bring inductive reasoning, top for a deductive reasoning where innovations come out, research topics percolate, and all these will happen for improving nursing. These are some of the models. I'm not going to speak about it. Each are very interesting model. Once we start enjoying apply these, we would see that there is a great clinical outcome that very gently, without anybody's knowledge, just coming into the scene, only we will see the outcome. But these all have to be imbibed and applied. For this, I've got few examples here. So this is what was a very, very simple model with which we started few years ago. Nurses understand this very clearly. So we put nurse on the top where she is able to see the individually when she's caring for the patient. She just builds blocks. So which is the block, right block. And then she also says that she's in the middle of the entire patient system. And then she also been supported by the leaders at the ground level, the policy, protocols, the evidence basis that is being put in front of her as a knowledge. So what did we do in 2020 was we just removed the aspect called as what went wrong. So we focused on what went right. So when we started focusing on what went right, we just gave something called as best catches. So we asked the nurses, come on, catch what is best. Do the best catches at the bedside, every shift. So what happened? In the medication error, we saw that the error decreased when the best catches improved. And you see, this nurse's satisfaction has improved tremendously when compared to 1919 to 2020. So this was a wonderful example I could give you, and it gave so much of delight. And we had presented it in our trust symposium last year at IHH Forum, which was well appreciated by 7 countries. These are some of the examples. All 4 categories of medication errors, nurses, there are examples, nurses are there, they have caught it, and this is what. And they get the delight when their photos come up, and to see that all the 800 nurses, when their photos came up for 2020, the best catches on medication error prevention, it was a delightful experience for all of us. Next comes the model, which is a very important model. This is a Hamilton Health Science model, where we applied this for nurses surprise rounding. See, nursing leaders visible in the ground. I believe if I had to say that my patients are safe, my nurses are competent, and healthcare delivery is going at least to the expectation of the minimum in our hospital, then I would only measure it during nights and during holidays. So we started off having a senior leadership rounds, surprise rounds during nights and holidays. With the focus, patient focus, nurses empowerment and well-being for us. We drink the tea that the nurses drink in the night and the snacks that they eat. We also understand if they need anything there. Then clinical process focus. Are they prepared in emergency? We got cold blues, midnight, 2 o'clock, just seeing whether they are able to cope up. At least nursing part, are they ready on it? So one area of improvement will be taken in each domain per rounding, and we focus only on that. So month after month, it is one round per month. Month after month, this helped us to improve, and Corona was not a bar for it. The next model that I would like to present here is our innovation, like prediction, escalation, and prevention. So here we know that nurses are able to predict, but the base knowledge is very important. What to predict has to be done, and why to predict is very important. And escalation comes with empowerment and the policy decision making. Where are they positioned in the organization? How strong are they linked with the clinician? And the prevention comes very quickly then. Then they have to understand the primary, secondary, and the tertiary kind of prevention that a nurse could do for each and every patient in the hospital. So you get a lot of clinical outcome because of this. A surgeon after a surgery will have a peaceful night without any disturbance because he is very confident that his handicraft has gone into the hands of a best nurse who's taking care of his patient. And this is the best example I could give you in the COVID ICU. This has really happened, and we were very happy to see that this smart young nurse was able to capture. You know, she just did the ABG and found that the patient needs escalation, and she also kept everything ready, just waiting for an order. And once the doctor did, then she proceeded with everything that is required for the patient. It was a wonderful example. And when we shared this moment of truth in the nursing council meeting, it was a great learning across all our 6 hospitals. And I would say, what is our strength? Our strength for the nurse is the nursing initiatives as a pillar. When we say nursing initiatives, is the nurse-led initiatives where we just go on onward march, where we take clinicians and others to our support. So CNOs, deputies, and assistant CNOs with clinical coordinator, and we have invested on 5 initiative team in all the hospitals where they have their own key result areas, they have their own quality indicators, they have their QIPs, and they have their link team. So everybody has got a link team where together they move forward. So it is like a military march towards the war, and how do we attack and then get the result. This is the last slide I would like to present. This is my interest slide. We always say that we follow medical model and we follow and borrow from other specialization. Yes, we did borrow this as well from PROMS. PROMS is the patient responded outcome measures. So this is specific to disease condition, and we wanted to be away from disease model as nurses. So what we did was like, we went on a model called as PRN COMS, where this is talking about the nursing outcome measures. This is basically for competency. We started off with IV. Just ask the patient, how do you feel when we stick on the IV into your arms, into your body? So the patient will say, oh, it was very painful. When we resuscitated patient, go back and ask them, how was the experience? When we did suctioning is the most painful procedure that any patient could experience. And when you go back and ask them, how was it when my nurse gave a suctioning? So they explain. So use those explanation in front of patient, in front of nurses, and the nurses can clearly understand. Nurses are smart cookies, I can say. They are very smart to understand. When they hear that the patient express, then they quickly modify their approach to patient. So we did this methodology also. It is in the process of doing, and I'm sure if we do it rightly and then present it appropriately, this will become a wonderful model for us to evolve into a best practice. And to conclude, I would like to say nurses and nursing leaders play an instrumental role in ensuring and providing evidence-based nursing practice. Now, what are the outcomes that it gives us? Lean nurses waste time. Everything we do repetitive, very traditional. Usha mentioned it very clearly. We are very traditional. Okay, why do you do every 4th hourly temperature checking for all patients? Is it necessary? Worth the time, effort, and resource used? Yes. So leaders must understand it's worth the time. So please spend time to transfer the evidence-based practice into reality. design delivery cost-effective care. It helps us. It helps us. It also delights the management saying that, oh, we have reduced costs. When we did this study, like how many PPEs are costed for a patient? So when we standardized it, 3 for ICU patients per day and 2 for the patients in the ward, patients are happy because the cost is optimized for them. And also the management is happy because more patients likes to come back to us for care. And empowered and mature. This is very important because the nurses get more mature, they become more empowered, and that helps them a lot. Improved nurses' job satisfaction. Nurses related outcomes are measured. So we are not interested in whether the patient went home with the clinical medical outcomes. We are interested in nursing related outcomes. That is what will delight my nurses. So we have to put in nurses related outcome. Patients came with a very huge pressure injury, but push core has been used and the patient been cared, and then in the entire pressure ulcer became normal. Patient went home. That is what our nurses are interested in. And patient related outcome, very important. And this outcome is again will help nurses to pat on their back. There is a 95% success in liver transplant. It doesn't go only for the consultant. It also goes to the nurses, because if the nurse had not continued the care properly, they wouldn't have seen the outcome. Evidence-based nursing care is a lifelong approach to clinical decision making. So we have to consider this as a lifelong process. And evidence-based nursing is informed by research founding, clinical expertise, and patients' values, and its use can improve patient outcome. So it is just not the patient outcome. There are many more to evidence-based nursing practice. Happy nurses can make happy patients. Happy nurses and happy patients can make a happy organization. Business will build it, will just grow, and I'm sure the organization will thrive. And not only thrive, it will flourish. So this is what I would like to share with all of you. And I vouch that evidence-based nursing practice is very important, and leaders have to show the way for evidence-based practice for the nurses as a top-down approach. Thank you, organizers, for having given me an opportunity. Sorry, the time is very short. I couldn't explain much. Thank you very much. I salute all the nurses for the wonderful work you do. And without a wink of an eye, in the midnight, you stand in front of the patient. You tried all innovations to keep the patients happy. You smile within your mask, and you do a wonderful job. Happy Nurses Day week and the year 2021. Year is for us. Let us move on and make a difference, and also set trend. Thanks, for the opportunity that you have given me. I thank all the physicians. I respect you because we travel with you. We are your partners. Thank you, and continue to support nursing. And I'm sure we will certainly make a difference with you. Thank you.
Thank you, Dr. Clara. Thank you, Dr. Arora and Dr. Susan Admala and Dr. Jyoti Clara for wonderful conversation and presentation on nurses' role. At this time, moving along, time is limited. Please honor the time allotted. So at this time, it's a great pleasure to introduce our chairperson for the next session, Dr. Vinita Sharan. And I'll invite her to introduce the speakers. Dr. Sharan is Associate Professor, Program of Radiology at San Beda University College of Medicine, Manila, Philippines. Dr. Vinita has a fellowship in computer tomography, MRI, ultrasonography, and breast imaging from Makati Medical Center, Philippines. Dr. Vinita was consultant, World Health Organization, Southeast Asia Regional Office, and India from June 2017 to November 2017. Dr. Vinita Sharan is country convener of GAPIO from Philippines. At this time, I'll request Dr. Sharan to introduce our next two speakers. Over to you, Dr. Sharan.
Good evening, everyone. And thank you, Dr. Arun Garg, for the kind introduction. I'm now going to introduce our next speaker. He is Counselor Mr. Rajiv Krishna Metri. Counselor Mr. Rajiv Krishna Metri is currently working as Senior Nurse CCU and Primary PCI Coordinator for NHS Trust, United Kingdom. Prior to this, Mr. Rajiv was a training officer for medical devices and was member of National Association of Medical Device Educators and Trainers. Mr. Rajiv was organizing secretary of International Nursing Conference. He has been chair for panel discussion at international level nursing conferences. He is founder and treasurer of Sumilan Cultural Association in UK. Since 2004, Mr. Rajiv is a member as well as player of North Wales Cricket League Abigail. He is also working as a councillor of Borrowdale Town at Dubbingshire Council, North Wales, UK. So I now invite Councillor Mr. Rajiv Krishna Metri to give his talk. The topic is Role of Nurses in Cardiology Outcome. Please welcome Mr. Metri.
Hello, good afternoon. Thank you, madam. Thank you very much for the brief introduction. I'm just going to share my screen. Is it visible?
Yes, Rajiv.
Thank you. All right, I'm just going to straight go to this topic. Thank you for this opportunity and happy Nurses Day to everyone. And this is this talk is not just about the numbers. It is not about just about the nursing. It is about the clinical nursing and also involves about the quality of nursing and also the quality of end of life as well. So please don't think that this is only, I'm talking about the numbers and everything. As you can see here, there are, according to the British Heart Foundation, there is heart and circulatory diseases is one of the biggest diseases, and which you use as an umbrella term. And this includes everything. These conditions could be inherited, or it is person born with them, or these conditions are developed later in our stages as we get older. With for example, like we might need a devices with the AF and other things. We may go into the heart failure, and we may have a myocardial infarction like a heart attacks and things. But most of the places when we come to the heart condition, we look as a heart attack is one of the biggest one. But working in the United Kingdom for 20 years as a in the cardiac department, the heart failure is one of the biggest problem. And a lot of people, we don't look into that one. And since the British Heart Foundation is established in United Kingdom, and they've just done a lot of these numbers, just about 7.6 million people in United Kingdom are living with heart and circulatory problems in the here. And every year there are 27% of the population in United Kingdom, the deaths are caused by heart and circulatory diseases, and that is much more higher than equivalent to the cancers and the Alzheimer's together. So which means about 163,000 deaths every year happens in United Kingdom. And that is just to show you and give an idea how many people is like Oxford, one of the big city in the UK, has got a population of 152,000 people. So it means every year 152,000 or 160,000 people vanishes from this world. So that's why this is very, very important, why our roles are important here. So we develop the integrated pathways. And these integrated pathways, why it is important? United Kingdom spends about more than £1 million they invested in these projects and the studies. And out of these 9 projects across the United Kingdom, 6 projects are only based on the community and the heart failure models, and remaining are focused on the cardiac rehabilitation and the arrhythmias. So these studies, what happens is they look into the nurses are involved very intensively. The role has been given, allocated, and they utilize the nurses for this kind of projects. And they do the studies with the transforming their ability, and they predict, they diagnose, and they treat the diseases. And there where the roles of every nurses comes. And so the more efficient ways to deliver these pathways of care addresses the funding, the value, and the efficiency gap and the unwanted variations of the care delivery. So again, the supporting these models of care. Yeah. So these supporting, no, there is no universal model has been identified to achieve these integrations. But the projects focused on shifting these elements of care from secondary to primary care, because the upskilling the primary care teams is very, very important, because when the money comes in, there is a lot of saving happens in the secondary care when the patient comes, because when we train the primary care teams, the primary care teams will look after the patient. So that's why if you look on the right hand side here, they collect the evidences, build the case for the change, co-design care and support pathways, mobilize the healthcare professionals, then inform and empower patients, carers, and the professionals. It's very, very important to involve the family members and the community members. It is not just the patients or the hospital or the nurses or the doctors. So it's very, very important to involve all these things. So developing the sustainable modes of care, improving the patient's outcome. So the cost saving due to this system efficiencies, such as reduction in the hospital admissions and the hospital referrals. And to do that one, nurses are involved into the improving the patient care, improving the pathways, and helping the multidisciplinary teams and collaborating across the organizational boundaries. That's how the nurses are going to involve into the different roles. And how is this developed? Yeah. So developing generic cardiology specialist nurses, this is then they expand and the remit of heart failure nurses, and developing British Heart Foundation nurses to manage a variety of cardiac conditions. I'm just taking the British Heart Foundation because it's one of the biggest organization here, and it's been here since more than 60 years. And they have done a lot of studies, and they've got lots of evidences. And if you want more information and things, please visit the BHF website and you'll get a lot of information. And cardiology is obviously increasing in the community clinics, day case, or community IV diuretics. So especially these heart failure patients, they present with the shortness of breath. And these things can be treated in the community by training the staffs in the community level area rather than bringing them to the hospitals. And that's where the specialist roles of the nurses come. And we get the education for GPs as well, primary care practitioners, and palliative care partners. With development of the new protocols and the referral pathways are as usual, and we'll review them accordingly, and enabling and supporting the patients to develop the skill and the self-care. And using this advanced role, how they develop and how the clinical outcomes. So initially, you need to develop your skills, recognizing the knowledge and the competencies. They are higher than those expected from a nursing role. So enabling the complex decisions making ability and clinical competencies for these expanded practices. So then in United Kingdom, the nursing role when you come from India or anywhere, it starts from either band 3 or band 4 at the moment to get it training. Then you develop into the band 5, which is a starting stage. And when we all came 20 years ago, we started at the band 5, and then we develop slowly to the band 6 area. And then slowly you go into the different specialties like advanced nurse practitioners or advanced clinical practitioners, and they can start from band 6 to band 7, or you can develop into band 8. And these nowadays, the advanced nurse practitioner, it is an older terminology or old term, but now they're changing into advanced clinical practitioners because of it is the word itself says the nurse, and the clinical nurse has been replaced by clinical, because before it used to be represented by the nurses. But nowadays, these roles have been taken by different specialties like physiotherapists and many other health care team members. They're taking those roles as ACPs. That's why it is replaced from the advanced nurse practitioners to the advanced clinical practitioners. And this is one of the things entered into India, which I'm very happy about it. And we are happy to support for that cause from our British Indian nurses team. And also we have a clinical nurse specialist, and these clinical nurse specialists also involved in the patient's care, organizing the admissions, discharge, and the cardiac rehabilitations. So these all kind of roles will be dealt with the clinical nurse specialist. And then come the higher, like above band 8. And if you go, you get a role as a nurse consultant. And nurse consultants also can look after the patient. They can involve with any kind of admissions, discharges. They do the rounds, they do the clinics. So they do everything, whatever the doctors does. So where in the cardiology, the doctor's role more comes into the, like a interventional or like a cardiac surgeons and things. So, but prior to that, everything is done by the nurses and the nurses team. And when the patients go home, it will be followed up by the nurses and the nurses team as well. So this is how the outcome goes on. And this is one of the chart which you probably not able to visible properly, but I'll quickly highlight about it. There is when the increased number of heart failure patients comes because involvement in the clinical trials, the research take studies, and a nurse role helps here as a medicine management. So they become as a nurse prescriber, and you can prescribe the certain medications, and you have all the full authority and the permission to prescribe to the medications. You run the clinics, and you do the appropriate referrals to the, whether it's a primary, whether it's a secondary, or whether it's a tertiary, depending on which role you have, you can referral system comes in. Competencies in the clinical assessment will develop, and then you are involving into the developing and the guideline, developing the protocols and the guidelines, and the scope of practice and the accountability comes. So most important thing is accountability, because whatever you do, it's very, very important that you document it and keep it record and everything. And that's why you are eligible. I mean, you are responsible for your role and the job, what you are doing it. And so this is a quick slide, I'll read it. So the British Heart Foundation, as you know, there is number of mortality rates have been dropped down more than 50%. And that's why the BHF is involving so much into the research and other works, and helping to develop more and more specialist nurses and support more and more specialty teams in the United Kingdom. And because the outcome is fantastic, and we work into all the three sectors, and we improve the community, helps to improve the communications, and there should be a communication. If there is a communication gap, it's very, very difficult to follow up the role. And we educate, support, we coordinate, and we do also have the improvement of the healthcare related quality of life in patients and the carers. And most important thing is we try to reduce the admissions. This reducing the admissions to the secondary or tertiary will save so much of money. It's not only about the money, but it helps the families. It helps the patient itself, because they can stay in their own place, or they can stay into the primary sector, and their psychological thing will come into the recovery of their diseases. And it's not only about when they're alive, but it also comes when end of life care. It's very, very taken it very, very seriously in this country, and we do look after the patients so well and provide the quality palliative care when it comes to the end of life. And these are certain benefits, as I was going through before, because in 2004 to 2007 we had about 76 heart failure specialist nurses, and they saw approximately 15,000 patients, and most of them had at least one home visits in their lifetime. But sorry, it's my alarm. So, but nowadays in UK we have 300 heart failure nurses in United Kingdom, but the patients numbers are increasing, obviously because of their lifestyle and everything. So obviously the need of the healthcare system is, demand is more, so obviously there are more number of nurses helping. And but whereas the program is delivered 35% of the reduction in all the admissions and significant cost. And just to give a quick figure here, 169,000 pounds, which is equivalent to 1.5 crore rupees in Indian rupees, is saved for every 1,000 patients here. And that is done the studies across the 26 sites in the country. So we also do the managing, supporting, and critical post-diagnosis period and everything. We work around the clock with the patients. So before I end, so I just wanted to mention last thing is, so as a role of the nurses in the cardiology outcome it is just not about, you know, looking at the numbers or looking at the patients, and it is also, it's about, you know, why we look nurses as a bedside nurse in India, but in UK and other foreign countries and abroad, they look just nurse as not just as a bedside nurse, because that thing need to come out of our brain. So unless and until, because nurse is a manager, nurse is a teacher, nurse is a clinical job, nurse is a so they got so much of role. They do the clinics, they do the everything. So with the care, compassion, and the fantastic communication with their love and affection, they just not only look after the patient, but they involve in empowering every team members, every persons. It's not about just the patient, along with the colleagues and the working people, and along with helping the organization. So that's at the end, I will just say, because as a member of the health team, that there is a dignity of labor, and that dignity of labor will help us to respect each other. So we'll give respect and take respect, and we practice it, we believe it, and we follow it. And that's the reason the status of nurses are always very high, and we want to maintain and continue to support for the Indian nursing sector with the help of all the leaders who are present here. And we want to thank you everyone for this greatest opportunity. And Year of Nurses is a 2020. And again, wishing everyone happy Nurses Day. And thank you, GAPIO, for giving me this opportunity. And thank you, one and all. Sorry, I just went over a bit of time.
Okay. Thank you, Mr. Metri, for your time and very, very informative presentation. And it's really very heartening to know that, you know, nurses doing their job well has really reduced the number of mortality. The mortality because of cardiac cases has gone down. That's really commendable. Thank you so much for your talk.
Thank you, madam.
So I will introduce the next speaker now. She is Ms. Thankam Gomez. Ms. Thankam Gomez is the founder and CEO of Signia Healthcare. Ms. Thankam is also the founder, president, and associate of Association of Nurse Executives in India. Ms. Thankam is a member of FICCI National Healthcare Committee and has recently been inducted into leadership group of Patient Safety Movement Foundations, USA. Ms. Thankam was the president of clinical services at Arohan Healthcare Services. Ms. Thankam has worked as an executive vice president at Berkeley Health Edu and as group chief of nursing at Fortis Healthcare. Ms. Thankam has received various awards like 50 Outstanding Women in Healthcare, Z National Healthcare Leadership Award, Women Leadership Award, and 21 in 21 Luminary Star Riga House. I now invite Ms. Thankam Gomez to deliver her talk on allowing nurses to speak up to improve clinical outcomes. Please welcome Ms. Thankam Gomez.
Thank you, Dr. Sharon, and I hope I am audible.
Yes, you are.
Okay, great. Good evening and good afternoon and good morning from various parts of the world. And first of all, let me place my humblest and happiest gratitude to GAPIO, Dr. Anupam Sibal, Dr. Tandon, and of course, our own Captain Dr. Usha Banerjee, because if you told me maybe 10 years ago whether this would happen, I would be doubting whether this is going to happen. So obviously we are peeping into the future, and that is what is the, the theme of 2021 Nurses Day. The theme is Voice nurse, a voice to lead, and looking into the future. So just give me a moment. Let me pull up my presentation. All right. So I'm going to keep a tab on my timing so that I do not exceed it. And anyway, my speaker friends before me made my life much easy because they have set the precedence, and Usha said, okay, it is time to think and say, make us your partner, and followed by Susan explaining everything about what we should be doing at various levels in the organization. And then of course, Rajiv coming and showing us, yeah, I missed Dr. Jyoti in between. She had spoken about evidence-based practice. So everything is pointing towards, they have set the precedents to say, allow the nurses to speak and get involved and then get better benefits. So today I'm only going to focus about why speaking up is important. And I usually try to be very candid in my delivery. I don't like to make up things. I would like to speak the truth, and that's what I'm going to speak today. So why should we allowing nurses to speak up? So this is a message from Institute of Healthcare Improvement. You can see up there where the nurse is telling, I actually want to hear the feedback, the nurses' feedback, but organization will not support that. So it is a little tough for me. And also I have high turnover. And so there is a lack of culture. I want to hear the feedback, but I have high turnover. There is a weak culture of safety. Now you look at the two pictures over here. The medical error in US, the third highest reason for death in US. Now, if you ask me, do I have something in India? This is what I could find out earlier. I never could find anything about India. So that is 5.2 million medical errors happening in India annually. And that is a whopping 14,000, almost 14,300 errors every day happening in the country. Now, the rest of the mathematics I'm going to leave with all of you, that how can we be smart enough to use nurses to improve the safety of the patient and to improve the clinical outcomes. Now, it's very important to understand why top 3 reasons why employees don't speak. Now, all the good things that were put across by all the speakers, they are not the norm, they are the exceptions. That is the reality, because I'm a trainer and I do a lot of nursing leadership classes, and I know that it's not the norm. We are still struggling with all the problems that Usha mentioned in the onset itself, that why nurses do not speak up. Not because that they don't like to speak up, it's because they are fearing that they would be viewed negatively, feeling that if they don't have enough experience, if a young nurse asks for a question, whether the clinician or the leader or the nurse leader or the management will turn around and ask, who are you? Why are you asking me? I have heard doctors who say that, who is the doctor? That's the only way they ask, who is the doctor? So now if we have such questions coming up, can we encourage our nurses? But let me also tell you the positive side of the story. I had been a very lucky critical care nurse who has been groomed by my ICU guru. Bless him, Dr. Vijay Kumar. I think he's somewhere in US now. I call him my ICU guru because he made me a fantastic, critical care nurse just by allowing all the nurses to speak up, because he allowed us that you have to speak up when you think that something is not safe for the patient. It doesn't matter whether the nurse is just saying, I'm not very sure whether this treatment should be given, but they are allowed to speak up. And the third thing is, feel that the organization's hierarchy is intimidating and unsupportive. Maybe the immediate environment is allowing the nurse to speak up, but not necessarily the organization is allowing them to speak up. Now, this is just a clipping I got from the internet, where it is actually in NHS, where a hospital has been warned for witch hunting the whistleblower. Someone who just discussed about something went wrong in the hospital. Actually the hospital went ahead and went after the person to make sure that they find proof to say who wrote this letter, because it was an anonymous letter. So these kind of environment exist all over the world, not only in India. So we say that speak up if you observe something unsafe. And this is the tagline for most patient safety. Now the question is, will they really like to speak up? WHO also talks about speak up for patient safety, and they have got this beautiful creative here where they say what are the components of creating a safe, culture. It is the safe culture that we are trying to look at, So I'm not going to talk about each component over there because that itself will take about 2 hours to talk about. So I'm going to ask some very hard question. Do we walk the talk? It's very easy to preach, very easy to say this all should happen, but can we make it happen? I believe that we can make it happen because I always say the clinicians and the nurses are the two sides of the same coin. And if we work together, we can literally bring miraculous outcomes, whether it is in the clinical practice, wherever that we are working, or whether it is in research, or whether it is in creating evidence-based practice. I would only say, allow the nurse to come forward and participate as a partner and then see the outcomes. And at the same time, I would also request all the nurse leaders and the mid-level nurse leaders also that we have to again walk the talk. Second hard question, are doctors willing to treat nurses as partners? When I ask this question, I am not asking this question to all those doctors who actually reap the benefit by making them their partners. Because I remember when I was a critical care head nurse, we were a team and we celebrated everything together. Are nurse leaders intimidated by nurses who ask questions? So I'm asking really some hard questions because I have experienced these things. Some of us, we don't like to have very smart nurses around. We don't want them to ask questions because that's the culture. We are very submissive. We don't like to ask our bosses any question. Oh, how dare you ask, So we all have to open up. If we want to get the benefit of speaking up, we all have to open up, and then only we will actually get the benefit of speaking up. Otherwise, webinars can be done in hundreds. Nothing is going to change. Now, are the organizations and training centers doing enough to instill the courage to ask why? So at Simon Sinek, the leadership guru says, we usually tell everyone what to do and how to do. The least that we explain is why. So if what I have seen is that when I was in the CCU, when I was working, we had our process of the nurse first telling the condition of the patient. I worked with my HOD to say, allow this to happen. My nurses will learn to speak very fast. And let me tell you that one intervention led to every single nurse, because I think nurses are quite okay to not to know things in front of their own nursing boss. They're fine with that. But they are very sensitive when they cannot speak in front of the doctor. So suddenly they all become very charged up and say, tomorrow I am going to tell about the patient. So even when the grand rounds used to happen, it was the nurse who will speak first. That was my HOD's mandate. So I would say that I was lucky to have fantastic doctors. I was lucky to have some great environments, but I have been in Indian healthcare scenario from 2001. And I think we are still missing some links to connect so that we can get at the benefit of nurses actually being confident and then, speaking up. The last but not the least is that, are we really willing to spend time to learn from medical errors? When I say medical errors, it could be medical, nursing, collaborative, together. I have been part of errors in hospital where everybody wants to find someone to blame. So do we have a culture that says that, no shame, no blame, and no name? Can we learn from that? That's the current discussion, is how to create a just culture. So most important question, when we talk all about this, do the front line, do they really believe in what the leadership say? One research done in US says the nurses there, more than 50% of them, they do not believe the leadership when they say, please report, please inform us the near miss, what mistake happened, you will be safe. They are not believing that. So the question is, how can we make that happen? What needs to be done? And why it needs to be done? I think with all the speakers speaking up today, the why part is very clear. Make the nurses partners. What will improve? The clinical outcomes will improve. How it will improve is very, very simple. Make the nurses your partner, allow them to participate in all the activities, whether it is making a multidisciplinary team round in the morning, asking the nurse, do you have any concerns for the patient? Allowing the nurse to stop the line. These are all the things which are practiced across the different, prestigious institutions. The question now is, why are we afraid to empower the nurse at the bedside to speak up when she or he feels something is not right? Allow them to say, okay, I don't feel safe. I think something is not right with the patient. In the critical care that I worked, we had the permission we had given to every single nurse. You're not comfortable when you look at the monitor, you say, oh, I don't know what's happening. Okay, doc, please come and have a look at the patient. I don't know what is happening, but please come. And they always respected the nurse's observation. And I'm sure that such great stories are there with all of us. Once again, exception. They are all exceptions. They are not the norm. And India is a big country. And I am so excited that I'm able to speak to so many people from different countries at the same time. And things are changing. I'm very optimistic that things will change, and they have to change for good. And we don't need COVID always to come and say, oh, nurses are also there. And I think it should not be an exception. Nurses are always there, have been there. And it's just that during COVID, we are getting a chance to expose them more. So I will leave with the last thought, allowing nurses to speak up to improve clinical outcomes. That is a question for all of us to answer. Thank you so much once again to GAPIO for giving me this opportunity to share my thoughts here. It's just 8 minutes we got. All of us were struggling to say whatever we want to say. But anyway, thank you so much. I'm very happy that I'm able to speak to so many doctors and nurses together. So once again, a very big thank you to Usha, Dr. Anupam Sibal, Dr. Tandon, and GAPIO, of course. And thank you once again, and I hope we will have more such deliberations. And to all the nurses out there, I wish I could say Happy Nurses Week, but I would say let's have a hopeful and prayerful Nurses Day and a Nurses Year. And that will always remain. Thank you so much once again.
Thank you. Thank you, Dr. Ms. Thankam Gomez. Thank you, Dr. Vinita Sharan, for chairing it, and both our speakers, Mr. Rajiv Matre and Thankam Gomez. At this time, I'll ask our co-chairs, Dr. Seema Arora and Dr. Vinita Sharan, to start QA. We are running a little bit over, so maybe we could manage some time. Over to you, Dr. Sharan and Dr. Arora, to manage the QA with the chat box.
I think, Seema, you need to unmute. Dr. Seema, yeah.
Can you hear me now? Sorry about that. All right. So thank you, Dr. Garg. I'm going to go ahead with the Q&A section now. And I would just like to tell anyone who has questions, please put them in the chat box, because there's where we're going to be reading them from and asking your questions. So I'll go with the first question. So as we all heard and we know that there are too many bright nurses here, but they're moving out of India. So what is the nursing leadership actually actively doing to retain these nurses graduates in India, or are they doing anything? I think maybe the Indian nurses counterparts can take that question.
Are you referring to me, Thankam?
Sure.
Okay. Thank you, Dr. Arora. I'll try to keep it short and sweet. The question is that so many bright nurses, but they are living in India, country, going to other places. I think some of it has been already addressed by Susan, who is a nurse in US, to say why we are having brain drain. There are many, many reasons. I think to start with the respect and the position the nurses get here in India. And also Susan mentioned earning a decent living by becoming a professional nurse. These are questions. And obviously the private sector or the corporate hospitals are definitely doing a fantastic job of training them so well, and maybe including the army, that so many nurses actually go abroad and make a great story of themselves out there. Why can't that be replicated in India? So it is not that what we can do to retain them, because obviously the first question, as the pink author said, the money part has to be first taken care of. Then comes the next of the want that is required in an employee. So I think that needs to be addressed for sure. And also most importantly that, if the corporates are doing their share of training them, making them so good that in 2 years time they are able to go abroad and settle down. So there is so much to be done within the country by looking at the way that we are training nurses, and when they come out, are they being taken care well? Are they being paid well? So these are some of the fundamental things that needs to be taken care. We can talk about 20 other interventions, but I think they all become a little weak because your basic thing is not taken care of. So I would request the authorities and the council and the government to come together to see that what can be done. It's very important to think about interventions not alone by private sector or alone by government. Think collaboratively, see how can we retain the nurses here happily. Even during the COVID, our nurses were leaving to abroad. Why were they going? It's not because they didn't want to stay back and look after the patients here. We have great story within, and we have greater story outside the country. So it's a hard question. I think we have to answer. Whoever is in the country, we have to answer. And any Association of Nurse Executives India is collaborating with other nursing associations across the world to see how can we bring in more discussions and then pitch all these things to the decision-making bodies in the country. So I'm sure we'll not give up. We'll do something for nurses in India, but corporate sector, the leadership is doing their best. I'm sure, because if they don't do the best, our best clinical outcomes from hospitals will not come out. Clinical outcomes are a combination of medical care and nursing care. Thank you.
Thank you, Ms. Gomez. Dr. Vinita, do you have another question?
Yeah, there's a question for Ms.
Madam,
Usha
can
Banerjee.
I just quickly highlight one more point about that question with the Thankam Madam answered? Being experiencing as an Indian nurse coming abroad, why nurses are leaving in India, the most important thing is there is no equality in the private sector and the government sector. They don't look after the same. And second thing, as Madam mentioned, said, roti kapda or makan, that comes first. And they're not well looked after, and it's not been well respected. And that's one of the thing I wanted to add to that one, because private and governments are not equal. Whereas in United Kingdom, where I work, private sector nurses get paid more, looked after very well than the government nurses here. So, but it is opposite in India. So I think that needs to be highlighted and looked after by our nursing councils in the state levels, and other nursing organizations along with the IMA and the GAPIO should involve and support the nurses for that, because we need to keep our own nurses in
I'd like
our
to
own
also
country.
make a point. I'd like to
Thank
make
you.
a point. This is Susan Adamala regarding this attrition of nurses to United States. To other countries.
Please go ahead.
So why the nurses are leaving is because first thing is, as we said, as I mentioned in the Maslow's hierarchy of needs, the basic needs have to be met, and then only the opportunities for higher growth to reach to the peak will be available to the nurses. And nurses in India, what nurses are considered is mostly that they are there to take orders. They don't have to use their brain, or they don't have any decision-making skills or anything like that. That has to change, because even the patients are experiencing nursing work every day. And nurses work at different levels. There are nurses who take care of activities of daily living. There are nurses who make decisions. There are nurses who do research. There are nurses who construct the whole EHR. So there are different roles that the nurses take over. So if everyone is working at a different level, and Indian nursing, the whole system, they just look down upon nurses as somebody who takes orders from the doctors, and that is totally wrong. And that is something that nurses need to educate. Also, I think it has to do something with our culture. most of the nurses are females, or it's a female dominated position. And, you know, by culture, females don't talk a lot. I have seen nurses, I've worked in India, I've worked in the United States, and I've worked in Middle East. A lot of nurses are Indians. There are physicians who support nurses from, you know, saying what they want to say. Like when we have a bedside presentation, or the nurses, we are taking rounds. If a doctor asks the nurse, she knows the answer, but she will not say that. And I have my students along with me, and I say, sister so-and-so, why didn't you just say? You knew it. Why didn't you say? And she said, oh, they're all doctors. What would they say? Or so, but when I ask my students from the Middle East, they're just student nurses. You ask them anything, confidence, I know. That's the attitude. That's how they're raised. That's how they're taught. We are taught, don't talk about yourself. But I think we should come out of that shell and say, I'm a nurse. I'm proud to be a nurse. I know my stuff. I'm here for the patient, and I can answer your question. So that has to be started from, from our school, from our nursing schools. We teachers have to teach them how to get to that level. And I see a big difference between my students in India versus my students in the Middle East and my students in US.
Very well said, Susan. Thank you.
Yeah, thank you.
Anybody else has a comment on? All right, we'll go to the next question then.
Yeah, I think related to what is being discussed about the relationship between doctors and nurses, there is a question, is there a reluctance from the medical fraternity to encourage nurses in advanced role in India? If it is there, then why is it there? And if it is not there, then what is being done to actively promote it? So anyone from Indian team probably would be able to answer that better.
I think
Jyoti,
I'll take that.
Jyoti, would you like to take that? Yeah.
Yes. I think I'll come in here. Well, I think like every country has gone through an evolution. India is also seeing that transformation, and we are at an inflection point. And I would say that we have come a long way in the last 1.5 decades. And I would attribute that a lot to accreditations. There is a national accreditation board, there is the Joint Commission, there are other accreditations, there's nursing excellence accreditation. So I wouldn't say it's a complete dark age. I would definitely say that we are in that path. We just need to accelerate our speed. We need to calibrate our pace and then leapfrog into the next level. And I think most of the nursing heads who are seated here are into this work. And I'm sure we'll see a tremendous change. But my request is, I understand that, everybody aspires to go abroad and make a better living. But good nurses have to stay back in this country to make that change too. If everybody is going to quit in 1 or 2 years, there is so little we can do. So humbly, I request many of you to go away, come back to India, make the changes like the doctors did, and I'm sure we will be on a path to progress.
Also, I would like to add that, it's not that only in India the physicians have a problem with advanced practice nursing. It's the truth in America too. We have a lot of nurse practitioners and advanced practicing nurses, but our physicians are not very happy about it because there's always a fear that we are going to take away their bread and butter. So this is a reality even here where the nurse practitioners have their own struggle. So we are also struggling in the same way. So I think you're not alone there.
But I think fortunately in India, especially like Tangam mentioned, and in some of the best hospitals, the physicians are ready to collaborate. They are willing to take that partnership. And I'm glad I work with one of the best hospitals, and Dr. Sibyl is my colleague, and they are for nurses. So I think the change will come.
Usha, may I?
Yeah, Clara.
Yeah, I would like to mention that it's not that only physicians are not allowing nurses. There is another angle to it as well. We have to earn it. See, for example, we have seen in our institutions, when we put our nurses in the front, so they are able to represent well. And in due course of time, doctors accept them to be in the front. Even if they say your prescription is therapeutic duplication, they come forward and say, oh my God, okay, I'll change it. So they change it, so they accept. But what happened is certain times, like we don't raise up to the level for them to believe us, trust us. So nurses, in continuation of learning, updating knowledge, and being smart enough to communicate, probably these are the angles we have to focus. I think there is a lot more work have to be done in preparing nurses to be positioned in front of the clinical team, that is a medical team, so that the medical team trusts us. I take it in this angle, and I think there is a lot of work for me to do as a leader.
I think
Thank
we
you
have
so
time
much
for one or two more questions. Please just keep track of the time. Okay, thank you.
Seema would be asking the next question.
So I see another question in the chat box. Do you think governing bodies in India should take responsibility for failing to set up the standards? Ms. Sharon, would you like to take that question?
Governing bodies in India, I'm not really sure what's been happening, but I would think I would be at a loss to answer this question.
I can answer that.
May I answer this question, because this is related to India? So I would say that it is not that the governing bodies, they don't have set standards or anything like that. The standards are all set, they are all available. Probably it is the manner in which it is executed. In different organizations, it is executed in different way. So probably execution and monitoring and holding people accountable for what is not being done. So all those things, as Usha told, the things are changing because of accreditation, and probably with advanced thought process among nurse leaders, things are going to change. So I will not like to say that there is lack of, policy setups or, standards, it's not like that. It is there. The gap is between execution at various levels and then further monitoring whether that is being executed correctly or not, because that is a complete process that needs to be set in place. So maybe there are some gaps there. That's the way I would like to put it.
I think I want to add a few points here. I think, what kind of schools get accredited, that's very important, because we have nursing schools mushrooming everywhere. Are they all meeting the standards? Because some of the students that I see, that they come here and then they're struggling to pass NCLEX. When you go back and see what kind of education they had, it's like they never went, they didn't have proper clinical setup, they did not see the patients enough, or they've not had experience. And I wonder sometimes, how did they even pass the exam? So I think, just like how we have NCLEX exam for licensure to practice and go into entry-level profession, there should be a licensing exam or something that will set standard for every nurse that comes out after her nursing education or his nursing education to practice. That will actually make sure that there is safe delivery of patient care and the standards are met. I don't know if I'm expecting too much, but I think this is minimum that we should do to have accountability for our profession and to be accountable to our population that we serve.
Already in place, Susan. It has already been muted, and it has already been proposed, and Indian Nursing Council has already done those points, and it's already been in paper. Unfortunately, the COVID did not help us to, work on those, good things that were being, proposed by INC. So I'm sure we just have to get over this crisis. This is very important. Right now, we cannot go back to policies and structures. We just have to get over this current crisis. Post that, I'm very sure, because all the good things which is being practiced by other countries are already discussed and proposed, and it is being heard, and it is going to be implemented. So I'm very sure all the other Indian counterparts sitting here, they will also agree with me that, as Usha said, it's not dark age for sure. It is not. We are going through a tunnel towards the light. And with all these things happening, for me, just sitting here in GAPIO talking is a great torchbearer to say things are going to change. And we are looking forward to that, and different nurses from different countries supporting us. So it is there, it is there. Common licensing exam and looking at their competencies, entrance, all those things are proposed and it has been accepted. So I'm sure that in due course of time, all these things will come into place. And I would,
Thank you.
yes.
Thank you. Thank you, Tankam. I think we
Okay.
are going to run out of time. As always, there's so much discussion, so much energy. We're going to run out of time. I think we are over, and think Dr. Tandon must be saying, how come Garg is not watching the clock? So please, at this time, I would like to thank our chairs, Dr. Arora and Dr. Sharon. Thank you for doing a fantastic job. All the speakers, I think the points you've been raising are just phenomenal. As a moderator or the chair of the session, I've been engaged with India for 10 years, and I just want to reaffirm what Thankam just has said. There is a lot of paper, there are a lot of protocols, there are a lot of processes. The implementation is just not there. We are hiding our head in sand if we say we are implementing. CINS has marched on a major leadership training program. GAPIO is doing a leadership program. If there is a one message, do it. And do it with energy, do it with passion, and do it with inner soul. Don't look to the West. Do it the way India wants it. And that's my 10 years of learning. And I would say, if the one thing we're going to change, give the self-affirmation, give the self-energy to people of the country, whichever that country is. Learn from other countries, but don't look up to them. Do the way you think it works in your culture, in your environment. And in India, without any doubt, I would say implementation is minimal, and we need to change that. With that, then I will, my last, sorry, moderator, not supposed to put the interpretation, but that's very close to my heart, so thank you. I would like to introduce Ms. Sri Devi Balachandran and invite her to deliver the closing remarks. Ms. Sri Devi Balachandran is a lecturer in Sultan Qaboos University, Muscat, Oman. Prior to this, Ms. Sri Devi was the Director of Nursing, Manipal Hospital, Bangalore, clinical specialist at PD Hinduja Hospital, Mumbai, and assistant professor at IT College, Nursing, Mumbai. Ms. Sri Devi is also registered nurse in UK and Australia. Ms. Sri Devi is the winner of prestigious P.N. Barry Scholarship Award and received an award for Best Teacher in Sultan Qaboos University in 2012. Ms. Sri Devi has published articles and research papers in reputed journals. I'll request Ms. Sri Devi Balachandran to give the closing remarks and bring the session to close. Thank you. Over to you.
Thank you so much, Dr. Arun, and thank you, GAPIO, for this opportunity. Currently, I'm an educator, and I'm really honored to be here to close the remarks. It was an interesting session, and there are so many issues. But let's talk of the topic, Nurses, a Voice to Lead and Vision for the Future. This very webinar indicates to us that if the doctor is the right hand, then it needs, then they need a left hand to clap. And if the right and the left hand, and the nurses could be the left hand or the right hand, whatever way it goes, this will complete the circle and this will bring about patient welfare. So voicing out and being heard will bring about welfare for patients. There are many issues, but let's get to some of them in India. I'm an Indian nurse. I'm here in Muscat for the last 17 years, but my home country is India. And there are many things that we need to do to raise our voice and have vision for the future. So there's something that I would look for in the future is that we need to provide assertiveness training. This is extremely important because I'm an educator and I can tell you how important it is to let nurses learn, students start learning. Like Susan Edamola correctly said, I don't even think it is to do with the education part. When we are born as children, we are taught to be obedient, and being obedient is nothing wrong, But I think being extremely obedient is what is causing us problems in nursing, and it is going throughout the profession. I struggled for nearly a long time to become independent. But when I had the leadership of Dr. LB Nesa Joseph, who was my administrator in Hinduja and later on my CEO, luckily he was trained in hospital administration from Washington. He realized that nurses have to be on the boardroom, and that is how I landed up being the director nursing, or the first director nursing in Manipal Hospital. So given an opportunity, a nurse who very much lived in India grew up to be a director nursing at a very young age and made magical changes. Because as a nurse, I believe that if we cared for our nurses, as a leader, I believe that if I had to care for my nurses will care for their patients. It's as simple as that. There are many issues of nurses leaving the country, and Rajiv happens to be from one of my groups. I think it's fine. We are a knowledge economy, and we let nurses go. In 2000, I don't know whether I should be proud or not. I let 300 nurses from Manipal who were well trained, who were able to speak, who could communicate, who could take classes, who could make decisions, leave. But today they are all backing me up from UK or from US and doing things to give back to the country. Yes, and I wish they would come back physically to change the processes, and there is still time and they are likely to come back. And so when we talk about leadership skills, we need to also think about critical thinking, integration. All this needs to start from their basic education. What nurses forget in our country is that we have independent roles and interdependent roles. All of us, after we train in India, go into the mode of interdependency or complete dependency and forget that we had assessments and we have health education and we have monitoring and so many other things that we could do by ourselves. Anyway, when we talk about whether physicians should support nurses, etc., in our country, in India, the rural area is a big place where nurses could practice independently. And so we should take this opportunity immediately. Definitely, we need the support of physicians, because if we could follow like Dr. Arun Garg just said, no need to follow the West, but you look at the areas that nurses could serve independently with a small 1 hour consultation weekly or some model like that, and they could rise to the occasion and be seen and visualized by the public. So policy changes need to happen. That as leaders we need to take up, and we need to knock on the doors of the government. No more education also talks about no, there is no need to get orders from physicians. Now there is everything standardized in most hospitals, protocols, except for drugs. We do not see the physician having to prescribe anything. The nurses could do their own decision making and do things. But there are other issues. Why nurses are not performing? Nurse-patient ratio. Nurses today in the COVID ward are looking after 40 patients. When do we improve this? The day we improve or realize that nurses need to be given reasonable work, we will see nurses rising up to the occasion. I have had this experience as a director of nursing, that if I raised the bar, the nurses climbed over the bar. It is just a matter of how much bar we raise in India, and we will see our youngsters going up. There are resources which are less. There is no evidence-based stuff that's available. There is no database available at the fingertip in the units that people work. There are no computers. So there are many things that we need to do. But if we are a voice to lead and we have a vision for the future and pick up one by one, like for example, like Usha said, just pick up one by one plans of upskilling, even a few nurses, or giving nurses positions, going to ask for much more places, salaries, basic skills. This will improve our country's position with regard to retaining nurses. This is something that I wanted to say. So even I know of nurses who are working in Assam in some village for a very little money, but they have respect, they have autonomy, and they have power to make the change. Just give them these three things: respect, autonomy, and power to change. Even if they are given less salary in India, they will be happy to work. Of course, money is basic. There's no doubt on this. I have come abroad. because I had at one point of time a personal trouble that needed to be sorted out financially. So women being women have a lot of responsibility, but there is a vision for the future. The nurse leaders that are speaking today, along with all of you doctors who are partnering, if you could help us just by even putting a word for us. For example, Maharashtra has made a pediatric task force for COVID. Can you believe there is no nurse on it? There is a task force nationally for COVID and for many other things in the medical side, not medical side, as in making nursing and medical commission, there are no nurses on it. So we have to ask for everything by ourselves. And we think we have the vision, we have the leadership, and we will get there at some point of time. Thank you so much. I haven't taken a lot of time to thank everybody because then it takes away time. Thanks, Dr.
Thank you.
Arun and everybody else.
Thank you very much. Thank you for summarizing so well. I don't know where the time went, just hour and a half had just flown. What a wonderful experience. As someone who lives far away from India, but whose heart is in India, this is inspirational. Thank you very much. This is great pleasure now just to thank everybody who participated, all our speakers, Captain Usha Banerjee, her team, and the chairperson Seema Arora, Dr. Vinita Sharan, and all other speakers, and especially the audience. I saw there were over 750 people who joined us. That's wonderful. And I will be remiss if I don't thank my friend, my colleague, Dr. Anil Tandon, who just works tirelessly to make this happen. So thank you, Dr. Tandon. Thank you, Dr. Sibyl, Anupam, and thanks everybody. Have a very good day. And tomorrow is Mother's Day in Canada. So on that basis, glory to all mothers. Thank you very much. Thank you for giving me the opportunity. Bye bye now. I think that brings the close to the session, right? Yeah. Okay. Thank you.